What if I told you the most expensive weight loss drugs on the planet are about to cost you $50 a month, not 500, not 1500, 50, and the agency handing them out won't tell anyone what the bill is going to look like? Let me explain what's actually happening here, because it's one of the strangest moves in modern American medicine, and almost nobody is talking about it. Starting in July, older adults on Medicare are going to be able to walk into a pharmacy and pick up Wegovy or Zepbound for $50 a month. Those are the two biggest names in the GLP-1 weight loss world. The drugs everyone's been whispering about at dinner parties. The drugs your coworker swears changed her life. The drugs that, at full sticker price, can run more than $1,000 a month out of pocket. And now, for a huge slice of the American population, they're going to cost less than a dinner for two. So here's the question that should be keeping someone awake at night. Who's paying the difference? Because that gap between $50 and $1,000 doesn't just vanish into thin air. Somebody has to cover it. And in this case, that somebody is you, the taxpayer. Medicare is the federal health insurance program for older Americans, and it runs on your money. Every dollar it spends comes from a pool that you and millions of other workers pay into. Now, here's the wild part. The agency in charge of all of this, the Centers for Medicare and Medicaid Services, still will not say how much this program is going to cost. Read that again. They are about to roll out one of the most ambitious drug coverage expansions in recent memory. It launches in a matter of weeks, and the people running it are not telling the public what the price tag is. Does that sit right with you? Because it shouldn't. Think about how strange this is. If your city announced it was building a new bridge, you'd expect a budget. If your kid's school added a new program, you'd expect a number. If your employer offered a new benefit, somebody in accounting would know what it costs. But here, with a national rollout that touches tens of millions of older adults, the answer is essentially a shrug. And the reason this matters so much comes down to who actually qualifies for these drugs. GLP-1 medications like Wegovy and Zepbound were originally developed for diabetes. Then researchers noticed something. People taking them were losing serious weight, not 5 pounds, not 10. We're talking 15 to 20% of body weight in some cases, numbers that used to require bariatric surgery. So the drugs got reformulated, rebranded, and approved for weight loss. And demand exploded. But here's the catch. Medicare, by law, has historically been barred from covering drugs purely for weight loss. That rule goes back decades to a time when weight loss drugs were seen as cosmetic, even dangerous. Think of the old diet pills that wrecked people's hearts. Congress wrote weight loss drugs out of Medicare coverage, and that rule stuck around long after the science changed. So how is Medicare suddenly covering these drugs at all? The trick is reframing. These drugs aren't just for weight loss anymore. They've been shown to reduce the risk of heart attacks and strokes in people with obesity and heart disease. They help with sleep apnea. They may protect kidney function. Once a drug has a cardiovascular benefit, the door cracks open. Medicare can cover it for that reason, even if the patient also happens to lose a significant amount of weight along the way, and that crack in the door is about to become a wide open gate. The $50 a month price point is what's being called a bridge program, a temporary structure to get these drugs into the hands of older adults who need them, while the bigger questions about long-term coverage get hashed out in Washington. But a bridge to where? That's the part nobody is answering clearly. Let's talk about the body for a second, because this is where it gets genuinely fascinating. GLP-1 stands for glucagon-like peptide 1. It's a hormone your gut already makes. Every time you eat, your intestines release a little burst of it, and it does several things at once. It tells your pancreas to release insulin. It slows down how fast your stomach empties. And it sends a signal to your brain that says, "You're full, you can stop now." For most people, that system works fine. But for some, the signal is weak, or the brain doesn't listen the way it should. You eat, and the off switch never really flips. Hunger hangs around, cravings stay loud. These drugs essentially flood your body with a synthetic, longer-lasting version of that hormone. The off switch finally works. People describe it as the food noise going quiet. The constant background chatter about what to eat next, when to eat, how much, just fades. That's why these medications have hit like a cultural earthquake. They're not willpower in a pill, they're a missing signal restored. Now imagine offering that signal to tens of millions of older Americans for $50 a month. The demand is going to be enormous, and the cost, even at deeply negotiated prices, is going to be staggering. Some independent analysts have warned that broad Medicare coverage of GLP-1 drugs could add tens of billions of dollars in spending per year. That's not a typo. A single category of medication could reshape the entire budget of the program. And yet, the official number from the people running this? Silence. Why? Why won't they say? There are a few possibilities, and none of them are flattering. Maybe they genuinely don't know. The pricing negotiations with Novo Nordisk, the maker of Wegovy, and Eli Lilly, the maker of Zepbound, may still be in motion. Maybe they know but don't want to say because the number would set off alarm bells in Congress. Maybe they're worried that publishing a giant cost estimate would scare off the political support needed to keep the program alive. But here's what you should sit with. When a government agency rolls out a major program and refuses to share basic financial information, that is itself a story. That is itself a signal worth paying attention to. Because the moment these drugs are flowing at $50 a month, pulling them back will be politically impossible. Imagine telling a 70-year-old who has finally gotten their weight, their blood sugar, and their blood pressure under control that the program is ending. It won't happen. Once it's in, it's in. So whatever the real cost is, you're going to be paying it. The question is just whether you find out now or after the bill arrives. And here's the part that almost nobody is asking. What does this do to the rest of medicine? Because if you're a doctor and your patient on Medicare can suddenly access a drug that helps them lose 20% of their body weight, you are going to prescribe it. Of course you are. The downstream effects on heart disease, diabetes, joint replacements, sleep apnea machines, even some cancers, could be massive. Some health economists argue the drugs might actually save Medicare money over the long run by preventing the diseases that drive most of its spending. Others say that math is wishful thinking, that people will stay on these drugs for life, because the moment you stop, the hunger comes roaring back and the weight returns. A lifetime prescription at hundreds of dollars a month, multiplied across tens of millions of people, is a fiscal black hole. Which side is right? Honestly, nobody knows yet. The drugs haven't been used at this scale for long enough, to be sure. And that's the deeper truth here. You are watching a real-time experiment on the American body and the American budget at the same time, with no published estimate of what it costs, with no clear plan for what happens when the bridge program ends, with no honest conversation about whether older adults will be on these drugs for 5 years, 10 years, or the rest of their lives. You're being asked to trust the process, and the process isn't talking. So what should you actually take away from all of this? First, if you have a parent or grandparent on Medicare who has struggled with their weight, pay attention to July. The $50 price is real. The access is real. For a lot of families, this could genuinely change a life. Second, understand that nothing is free. Somewhere the difference between $50 and the true price is being absorbed. Probably by you, possibly by future cuts to other parts of Medicare, possibly by added strain on a program that already faces long-term funding questions. Third, remember that medicine is never just medicine. It's policy, it's politics, it's accounting. The pill in the bottle is the easy part. The system that decides who gets it, at what price, and who pays the difference is where the real story lives. And finally, ask yourself this. If a program is good enough to launch, why isn't it good enough to budget for in public? What does it say when the people in charge of spending your money won't tell you how much they plan to spend? Maybe the answer is boring. Maybe it's bureaucratic. Maybe the number is coming next week. Or maybe the silence is the answer. Maybe the real cost is so big that nobody wants to be the one who says it out loud first. Either way, in July, the pharmacy door opens. The drugs start flowing, the bridge gets built, and somewhere a meter starts running on a bill that nobody has shown you. Keep an eye on that meter, because sooner or later, somebody is going to hand you the receipt.